hypoglycemia as well as hyperglycemia are alarmingly dangerous.
So it's like a war which is unleashed on the body is trying to fight, and at that point of time.
But obviously overfeeding is something that is not really helpful and is probably more harmful than beneficial.
Above 180 sugars, things are significantly not right, and we should try to control the sugars with the insulin.
Having low sugars are much more dangerous than having a slightly higher sugar.
Stress, catecholamine release, sympathetic drive, procedures, pain, all of these things are shooting up.
So that comes to a very, very important question, and I'll probably ask you this question. Welcome everyone. Today we are discussing a topic that sits at the heart of critical care illnesses and physiology, and that's dysglycemia in the ICU. Well, now when we say dysglycemia, it just doesn't mean high sugars. There's a lot of stuff that happens on the background. There's a lot of catecholamine surge. There is uptake of the cortisols. There are down regulations of various other hormones, cytokines, glucagons. In short, it is a complete reprogramming of the endocrine system that occurs when there is dysglycemia in the ICU. All these things occur, and this is what makes this an extremely complex illness. Now, what's more important in the complexity? The complexity comes because of the fact that both hypoglycemia as well as hyperglycemia are alarmingly dangerous. Now, after the NICE sugar study, we've understood that we are rather safe than sorry, and we're really not going up or going down, and we've come into a zone of control and actually safety. And layered on top of all of this is actually nutrition. Every gram of carbohydrate that we actually give interacts with this complex physiology, with this background, with this complete surging of cytokines, and on top of it we add an insulin therapy. So managing dysglycemia is not just about insulin drips, it's about coordinating physiology, coordinating inflammation, and coordinating the feeding together. To explore this, I'm actually joined by none other than Dr. Ansari, who is the Director of Intensive Care at the Max Nanavati Hospital, who comes with loads of experience. Dr. Jay Kothari has been a bedside intensive care for a very, very long period of time. He is the Director of the Apollo Hospitals at Ahmedabad. And we joined with a combination who's going to take us through the metabolic and substrate utilization by Dr. Asrani Varsha, who is actually the advanced nutritionist at the Oakland hospitals. Well, let's begin at the bedside. Okay. From your perspective in the ICU, I mean, we are seeing so many patients who come in with, who are being on vasopressors, being on steroids, being on various kind of medications that we have. What do you think is the biggest driver that leads to dysglycemia?
So, Sanjit, as you very rightly opened up, that when we are talking about a highly critical patient, he's already battling at multiple fronts, internal and external. When we talk about sepsis, inflammation, trauma, stroke, neurological, cardiovascular problem, we are looking at body which is struggling at various counts. And at that point of time, it's flight or fear-driven psychology, as well as an internal physiology which is on like nitro, on a high drive, which is catecholamine surges coming in. Your body is wanting enough glucose circulating inside. It has been shown even on genotypic studies that the glucose upregulator receptors are kind of gone up, so that there is all a massive influx, outflux of glucose happening. Those organs which need glucose will need it, but blood is steaming with a kind of glucose, so that none of these fighting mechanisms are short of glucose. So it's like a war which is unleashed on the body is trying to fight, and at that point of time there is no fine tuning required by the body. The hormonal systems are kind of sitting quietly, watching what is happening, if I can simplify that, and glucose is reaching in abundance. It's usually either a vasoconstrictive kind of state where it is still into the macro circulation, or it is a vasoplegic or a vasodilatory condition where the glucose is reaching to the tissues where the war is happening, like in cellulitis and other situations. So in general, drugs, stress, catecholamine release, sympathetic drive, procedures, pain, all of these things are shooting up those mechanisms which are releasing glucose in the bloodstream. So hyperglycemia can be an index of severity of insult, but majority of the time it is failure of a fine tuning of a metabolic construct. Okay. So if you ask me, it is both a severity indicator of the insult, but more importantly, the loss of control of the metabolic milieu which leads to it. And then obviously the premorbid illnesses, if you are already a diabetic or a pre-diabetic or you are on the verge, you were dysglycemic, and as you rightly said, dysglycemia is not just going up of glucose, but falling down or glucose variability around the mean. So this only shows that a lot of metabolic cacophony is happening in the blood. Body is striving hard, fighting everywhere, and it needs fuel. And that's the best fuel available till lactate kind of comes in as an automatic, kind of substrate, especially in anaerobic situations.
Correct. So what I understand is this kind of physiology is a more hormone-driven physiology, which is superimposed with extreme inflammation. This is what I get from you. So from a physiological standpoint of view, Dr. Jay, how do you interpret that? Is this primarily an increase in the hepatic glucose production, or is it that the peripheral glucose uptake is going down, or is it just the steroid that is causing it, or is it just something that is very primary in the sepsis physiology causing it, or is it the nutrition that is causing the sugar to go up? I mean, what's your point of view on that?
You see, the hyperglycemia in severe sepsis or septic shock is probably multifactorial. On one side, the production of glucose is increasing, and on the other side, the glucose utilization is decreased. So physiologically and through the endocrine perspective, it is both. The production has increased and the uptake of glucose by the muscle, by the adipose tissue has decreased. And there is a significant hepatic gluconeogenesis and hepatic glycogenolysis, which creates serious and significant production of endogenous glucose, which is because there is a insulin resistance at the muscle and the adipose tissue level. This glucose cannot be utilized by muscle, and there is a decreased consumption of this glucose. Both this factor would lead to serious hyperglycemia. This hyperglycemia actually is an adaptive response for the body to help the vital organs survive better. It provides the substrate so that the vital organs like brain, kidney, red blood cells and the immune cells, which are hyperactive, would get the adequate substrate easily, and the sugar is this adequate substrate. The body, in relation to the serious stress or in relation to the significant sepsis, produces this hyperglycemia to support the vital organs.
Fantastic. So this means that a body kind of reprograms itself to release the glucose as a part of the flight and fight response. This means to say that there is a good production as well as reduced utilization of glucose, and that's why the body is flooded with glucose at the time that the patient has got kind of sepsis. So here I would like to get back to Varsha. So on the background of this, we are actually adding an exogenous substrate. If you look at it, we are adding feeding on top of this already glucose overload or dysglycemia that we call in these cases. How do you think about feeding in this context that we are talking about?
Yeah, so from a nutrition perspective, obviously that first few days when a patient is in an intensive care, obviously the body is going through the whole cascade or a plethora of cytokines and hormonal changes and triggers, which is actually actually releasing a lot of endogenous glucose. So almost there's about 300 to 500 grams of endogenous glucose that's released, which often gives the patient enough calories to maintain survival at that point in time while they are actually just going through this whole cascade. But at that point, feeding should be initiated, of course, and trophic feeding, which is feeding at a lower rate, trying to sort of, which is called as permissive starving, is possible and it should be done. But obviously overfeeding is something that is not really helpful and is probably more harmful than beneficial. Particularly in the light of evidence which has been over the last 10 years or so, there has been this whole thing about hypocaloric feeding in the early phase, particularly because of this whole hormonal and metabolic change that happens in that early few days. You want to kind of make sure that the patient is not being overfed. And particularly there's some breakdown of protein, but that is not aggravated in this first few days. Over time, maybe in that end of first week or after day 4 or 5, this starts getting worse. And that's the time when feeding should be introduced at a more targeted rate. This whole process that we try to prevent inhibition is autophagy, particularly in the critically ill. So feeding should be initiated, to summarize that, and as early as possible, but we shouldn't be overfeeding patients.
Correct. So feeding is definitely integral when it comes to any patients in the intensive care unit. Now let me just digress a little bit and go back to critical care physiology. And I'll ask Dr. Jay, as of now, what is the way what are your targets when it comes to glucose control in the intensive care unit? What are your targets and why do you do those targets?
We usually target sugars between 140 to 180. The concept of very tight sugar control was once upon a time coined very heavily, and then we realized that it is creating more number of hypoglycemia episodes and the adverse outcome related to the hypoglycemia. And over a period of years, the zest about creating a serious strict control of sugar has reduced. Now we allow the sugars between 140 to 180, but I would like to still mention above 180 sugars things are significantly not right, and we should try to control the sugars with the insulin which needs to be administered to the patient.
Correct. So you've basically taken the advantage of being under control, but at the same time not going beyond the safety girdles, which is 140 and 180 is what you say. Yeah, we completely agree to the fact that having low sugars are much more dangerous than having a slightly higher sugar that we have in here.
Hyperglycemia
Correct.
is the term
Correct.
that has been coined, but
Correct.
not the severe hyperglycemia.
Correct.
If that happens, it has got its own bad effects.
Correct. So we understand that moderate sugar control is kind of what we require. That's the word, moderate sugar control. But let's take if there's a patient who's at 0.2 units per kilogram per hour. Let's take that is at 0.2 units per kilo. This is definitely a steep dose. I mean, you look at 0.2 units per kilogram per hour. Would you call this now glucose control, or would you call this that this has gone beyond glucose control and it is in the marker of extreme metabolic insult or severity? I mean, when would you call it 0.1 or 0.2, or is there a number which will tell you that, okay, from here onwards, it's more severity of an illness rather than glucose control here?
So an insulin naive population or a non-diabetic patient?
Let's take both.
So when you talk about a person who is already on a kind of a diabetic diet before he came to the ICU, was struggling with his glucose control, glyco-HbA1c was, let's say, 8.5 to start with. Now this person is already into a metabolic firestorm before he came to us. Now here, if you put a number, it doesn't do great service. He was living with a number, if you calculate that average glucose was in 200 plus. So that gentleman, when he comes to the ICU, if you find a value of 240 with a stress, I think that's an appropriate bodily response for that situation. And if I want to target it down to 180 and below, I will be obviously needing a good stiff dose of insulin at that point of time, and there would be, mind you, IR, insulin resistance involved. So I'm not very big fan of these numbers per se, but I would like to look at more than two values. Especially it is a recommendation that you check your sugar, look at the glyco-HB, do at least 7 sugar values in a day. This is what our Indian consensus guideline talks about. 7 is because you keep some sleeping time, if at all, into abeyance. And if you kind of do, let's say, 4 or 5 readings of sugar in a day, which are crossing the 180 mark for any individual, whether it is diabetic or non-diabetic, now you are going into more than just metabolic fluctuation. This person is into a kind of total metabolic loss of control. And that can be because of inotropes, a stressful scenario, pain, and a lot of other things, probably starving or overfeeding, all of this background. And if he is diabetic, then I am very, very concerned in any ways to start with, because he is at the high risk of vascular complication, cardiovascular complication. He already has a huge debt of poor metabolic control. So to simplify, I would say that when I am looking at the amount of insulin required, and I am talking about both diabetic and non-diabetic, without any major stressor like inotropes, like 3 inotropes going on, all the set on, and the patient is on steroids as well. Now here probably I need to not focus only as the primary driver as the insulin, rather the disease which is causing it. If it is sepsis, inflammation, some kind of cytokine storm, I focus that this gets better. But if I see that, oh, it is resolving and still sugar is going out of control, and he is a diabetic or a non-diabetic, both the ways, now I need to focus my energy on a strategy which is basically about the glycemic load that he is getting, then looking at the substrate which he is being fed, and getting into a better, more what is called continuous feeding, if I can do a lot of other tools that we can employ at this point of time. But remember, hemodynamic unstable patient and hemodynamically stable patient will have totally two different sets of metabolic derangement. So I would say, if you ask me this, I will ask what is the hemodynamic status. You say hemodynamically stable, fair enough. Now we are looking at a metabolic disruption. Hemodynamically unstable, it's a result of the basic problem at hand.
Severe physiological
ARDS, severe
stress.
failure.
Correct. So I like the way when you said that, it's like an inflammatory storm that happens in this case. Barsha just told us we would never delay feeding, and we would like to feed them quite early. That's quite interesting.
This is more of uncontrolled stress, which
Correct.
is leading to
Correct.
uncontrolled hormonal
So
milieu.
so that's very interesting actually. If you ask me, it's actually very interesting for me, because intuitively what I feel is, if there is going to be a high sugar in the body, we always feel there's a tendency to hold back. There's
That's
always a
not right.
tendency to hold back. Now that's the temptation. That's definitely a temptation. But we're all saying that nutrition actually remains a priority in this. So that comes to a very, very important question, and I'll probably ask you this question. So is there a level of fluctuating dysglycemia which will prevent you from starting an enteral feeding? Is there a level, for that matter, where if there is fluctuating dysglycemia that happens, and you would say, no, let this patient, let him wait for some time, and then let's go ahead and feed this patient? Is there any level that way, or you would not even consider that to be anything?
And I think that's a really good question, because we always tend to associate feed or food with blood sugars, which is a very common way of thinking, isn't it? But as we've been discussing this whole thing about this metabolic storm, and how the patient is actually in that very crucial stage, particularly when they are very hemodynamically unstable in that early phase, holding feeding is not going to actually be doing anything different if the patient has this whole metabolic state. That cytokine storm which the patient might have is not probably going to prevent that. I think what is important is how you strategize the feeding, particularly in that early phase. You want to start trophic. You're not escalating requirements to meet the patient's requirements, and particularly the evidence says that actually escalating requirements to target is probably going to make things worse, and the patient might require more insulin, which will then go at a different trajectory. But I think in the early phase, you just want to try and give some feeding to keep the gut viable, but also try and get the patient to sort of have some trickle of nutrition going in there. It's only after a few days, when the patient is hemodynamically stable and the whole acute phase response has diminished, that's when you would try and aim to at least 70 or 80% requirements, depending on what the patient is on. If they're on things like propofol, then you would account for things like propofol, or if they're on steroids, you are expecting the blood sugars to definitely go high, and in that case you would just maybe adjust your feeding to that, but you won't necessarily reduce the rate, or you won't necessarily stop feeding, because I think that's going to lead to a lot of breakdown of muscle protein and nitrogen, which is probably the next major complication. And often we don't realize that early in the ICU, because we're trying to keep the patient really alive and focus on survival. But what happens is the impact is quite later on, in the post-acute state, when the patient is in a more rehab state, where the impact of poor nutrition from early ICU can start showing up. And that is muscle breakdown, functional, problems.
Correct.
Yeah.
So this I mean, what you say is that dysglycemia is not a reason to actually starve the gut. This is what you basically said, that irrespective of what the glucose is happening, we still need to feed this patient.
So-
But I have a question, and this question would be to you, Jay. If you are feeding these patients, you are actually putting up the insulin requirements to go higher. That's very clear. I mean, the moment you start feeding them, the insulin requirement starts going up. So are we really metabolically helping this patient, or we are increasing the burden of our work? Are we really doing something good to this patient in early shock? I'm not talking of those patients who have been in the ICU. I'm talking of early shock, say the first couple of days. By doing this early feeding, are we really helping this patient, or are we just increasing the metabolic burden of coming out of that shock in these particular individuals?
We'll have to learn and understand one thing, that early feeding is definitely going to help the patient to prevent the complication of future, as rightly mentioned. Now, this early feeding does not mean the full feeding or the full calorie protein targets that has to be achieved. If we try to do so, body is producing already a significant proportion of endogenous glucose, and there is some protein catabolism leading to higher protein metabolism also. So, we do not really need to go full-fledged about either calorie supplementation or protein supplementation. We will have to be very hypocaloric and hypoproteinemic in the initial first couple of days or 3 days till we achieve this hemodynamic stability, till the stress comes down, till the patient's need for steroid, till the patient's inflammatory markers and the cytokine storm settles down. And once that happens, we step up the nutrition towards the target. And in continuation of the previous discussion, that I would like to say, of course, high glucose needs high insulin, and at the same time we do not restrict the nutrition to be given in the early phase, but in some difficult scenario when the insulin requirement goes seriously up, at that point of time we need to carefully monitor the phosphorus, magnesium, potassium and so on and so forth to prevent the metabolic difficulties arising because of the cellular shift of these electrolytes, and we need to frequently monitor such kind of things. And if the phosphorus or potassium or magnesium goes seriously down, either it needs supplementation, or at that point of time in difficult to treat situation, we may have to go down to the current nutrition temporarily, understanding that very high insulin supplementation should not create this kind of additional metabolic stress.
Correct. So let's take the example, now that I've understood that you need to feed them, let's take the example of an individual who's somewhere at 0.1 units per kilogram per hour. It's a very high dose of insulin that is on. Ansari, would you even think, Dr. Ansari, would you even think that you would change the feed in such a way to reduce the insulin requirement? Would you even think that first? First, would you even think of changing the feed in your practice to actually ensure that the insulin levels are a little bit better? Because we give insulin, and as you rightly said, the electrolytes are going to be haywire the moment you start giving insulin at very high doses. So the question that comes to you is, would you even think of changing the way we feed? Forget the formula, the way we feed, as in whether it should be intermittent, whether it should be continuous, whether we should give breaks. I mean, any of these things, are there some things that you would do in order to see whether I could reduce the insulin requirement? It's a very difficult, tough question to answer.
So at the cost of sounding little repetitive, I would always, whenever this happens, because you need to just step back a little bit, look at your patient, and this is the time where you personalize your nutrition. Look at your patient on 3 kind of different areas. One, what is the patient I am dealing with? Is he already a malnutrition patient? A person whose protein sarcopenia is already there? A person who can't withstand this insult because he is not fed well? Or a person who is a healthy young athlete who had come with an MI and got a cardiogenic shock, is on an IBP and this. Why am I worried about there for my nutritional targets in the beginning? While somebody in an onco survivor, a patient who is going through multiple chemotherapy is going up and down, and this person is coming to me with sepsis. Now these 3 different patients, looking at their Nutrix score or any score that you do, subjective assessment, whatever you have done, you know that this is high risk of malnutrition, low risk of malnutrition. This gives me a lot of handle to play around with my feed or with my other strategies. Number 2, when you look at the kind of hemodynamics that we spoke about, is he coming out of a shock or going down into kind of bad situation? When you are going downhill, you know that warriors don't need to eat then. You need to just fight over, come out of the obstacle. But again, some people who are really poorly, impoverished or who are not nutritional, they will need that also. There I would accept a little higher sugar values, not be in a hurry to, pump in insulin at that point of time, because it will go up and down because of the sympathetic drive, as well as a person who is fighting it out in poorly challenged, poor, glycogen reserves. And the third part is that feeding constitution. So that is very important, but this is probably 1/3 of importance. If I look at my feeding quantum, what I am giving, whether I am giving intermittent or continuous, that's very important. Continuous is the easiest way to get a better control in these situations. Not physiological, but very important adaptation when you want to fight with the glycemic battle or glycemic variability or dysglycemia. Number two, what is the constitution? Are you giving kitchen feed, blend rice feed, or you can get to a specialized glycemic targeted nutritional strategy. That is something which is, if I am not wrong, that is what we call as GTCN or GSTN, whatever you call it, GST like. Something you have targeted there, where you can think of getting SC, short chain fatty acids, your MUFAs, your PDACs or whatever proteins, and get into your glycemic load and carbohydrate counting at this point of time. So once you are now, so I would not do this first. Let me put it this way. I will let her to do that. She's gonna help me, guide me. Dr. Ansari, why are you feeding like this? Why don't you do that? That's something input I want. But let me look at these 2 points. What patient am I dealing with? Does he need intensive nutrition? Or we can go slow on him. Pancreatitis, why am I pushing him in gut ischemia? What am I doing? Go easy, go down. Trophic feeds, as Jay very rightly said. And number 2, look at what disease I am dealing with and which stage of disease I am. And I have to do a catch up later on. That's very important, because at the end of 7 days, either my patient has to get better with a good nutritional goal on the or a bowl on the plate, or otherwise he has to be kind of seen through those difficulties which he is unable to navigate.
Correct.
So I hope I.
So, Dr. Ansari, you've actually said that you would get to Dr. Varsha to understand what this needs to be done. So let's just get to her. All right. So, on a practical note, if you have this dysglycemia that's occurring, okay, would you alter the feed composition? For that matter, would you give a diabetes specific formula that is available, which is made scientifically for diabetic patients? Would you do that in the intensive care unit?
Yes, so in my practice and experience, we've had as Dr. Ansari said, there are different kinds of patients. So, what have they come in with, what's their etiology, but also what's their body habitus. So if you have someone with a lot of comorbidities, high BMI, often a diabetic feed with some fiber will help, because it's got a better metabolic profile. One of the most important things that we should consider looking at food, like a feed composition, would be protein. So something which has got a moderate to high protein would definitely be more beneficial for any of this kind of condition, particularly where the blood sugars are becoming quite difficult to handle. We have been giving insulin at very high doses, and I think just modifying it to a high protein feed or a moderate protein feed with some fiber, sometimes short chain fatty acids for the gut, that sort of profile would be really ideal for a patient like that. So yes, sometimes we have to alter the feed depending on what the patient's situation at that point in time is, and maybe it's different for say for example a pancreatitis patient, they may not be absorbing, so we might have to adjust the feed slightly. For a patient who's had a cardiac surgery, is completely different, so we might have to adjust the feed slightly. So really depending on the patient at that point in time, we might have to adjust. And I guess when they reach to a more stable state where they are absorbing, they have come off the shock phase, then you can probably go to a more standard feed which is giving them enough protein still, but you just kind of monitor their blood sugars then.
Correct. Yeah. So there's one question I'd like to ask around this aspect. She just said that a diabetes formula which has fiber would probably be a little bit better, and she told about the fact that these diabetes formulas do have fiber. So there are a couple of studies on non-ICU patients where postprandial glucose does come down. But does it happen in the ICU too with these fiber?
The fiber side of things is slightly more, there's not, I guess, not very strong evidence to suggest it might happen, because I guess in the intensive care, the whole thing around fibers, we don't have enough robust studies or enough randomized control trials telling us that. So I think that is a slightly different area. But in saying that, in our ICU, we do use a lot of fiber. Yes, we do use, but we also give them insoluble fiber in certain patients. And that's just because it necessarily doesn't do much harm, but it might be also useful for bowel health. So I think it's probably not a bad idea. If you think about it, in a healthy person, you need up to 20 to 30 grams of fiber in a day. And in an intensive care unit, this patient is probably, if they're not getting fiber, it's probably not normal, the usual standard care. So just giving them 10 or 15 or 20 grams of fiber is not going to necessarily do any harm. And we would probably be more pro-fiber in those patients as well.
So what we hear from Australia and from New Zealand and from all of these countries across the Western literature is the fact that they need fiber, and they start at 20 grams to 30 grams total, right? So and that's a very good takeaway that we have. Now I would put this question to both of you all. Okay, in your years of experience that you've had in managing patients of intensive care unit, has the use of specific formula modulation, like how she says, changed the clinical trajectory or just changed the insulin requirements? Has it changed the clinical trajectory or has it changed insulin requirements? Is it just chasing numbers?
It's just chasing the numbers. I would say more likely that we want the insulin in, we are comfortable having insulin at a particular dose. That's how it is. If the patient has very high insulin requirement, what I personally feel is that means the stress, body stress or the disease severity or the physiological derangement is not yet settling and the patient has serious high insulin requirement because of the insulin resistance and because of the serious endogenous production of the glucose. So, trying to give the formula feeds or trying to change the composition of carbohydrate in the enteral feeding or in the feeding would decrease marginally the insulin requirement and would probably help attenuate the glycemic variability, but not the primary difficulty which is the disease and primary difficulty which is the stress response to this disease.
Correct.
So, changing these formulas would help managing the glucose, but not treat the patient. So, not change the trajectory.
Change the Ansari?
I completely agree what Jay said. Only one thing, the only single what is called constituent of nutrition which really, if not actively looked for and changes the outcome, is protein. And that is where, and it is very clearly shown in a lot of research that protein helps in secretion of GLP-1. So that's the natural way in which even off the ICU or in the ICU, if you are no safe guardrails for not over giving protein or adding to some gastric distension or poor tolerance, protein is actually the sump which kind of allows you to get the real nutrition that the body wants. At that point, it doesn't need really carbohydrate all the time. 400, 500 is enough, and beyond that should be a protein building block which is easily possible to be assimilated, and that has a lot of effects on tempering these glucose swings, in my opinion, and a lot of evidence talks about that. So there are certain good scores, composite scores for knowing the digestibility of the protein if you can supply them in reasonable amount along with these strategies of SCFAs, MUFAs, and probably complex carbohydrates without having very high glycemic indices. You are actually giving up easily what is called digestible glycemic specific nutrition, which definitely brings the glucose down. Whether that alone makes the outcome change, no, other two parameters are there. How bad was your patient to start with? What was the disease and the severity to start with? These two will take away the cake most of the time. But this will definitely be the icing on the cake. Because if you are able to do that, get a good number flowing in, good balanced nutrition which is targeted to the patient's requirement along with the dietitian who is mapping, because the requirement may suddenly improve when the patient starts moving out. He is now needing more energy to move around. He is lying down. You don't want that person who has come out of shock but is hardly able to move around, no physiotherapy, doesn't have strength, goes back into some kind of compensatory anti-inflammatory response syndrome after 7 days and comes back to you in the ICU.
Fantastic. So this conversation has been really fantastic, where we've understood how critical illness modulates the stress physiology and gets things into control, and how dysglycemia can play a very important part when it comes to recovery from critical illness. We've also learned a lot about feeding these patients and how protein behaves as a glucose sink in this nature. And also we've learned how modulation of feed might benefit these particular patients. Thank you, Dr. Varsha, Dr. Ansari and Dr. Jay for this enlightening conversation, and until next time, Shabba Khair.
Thank you so much.
Thank
for
you
having
very
us.
much.
Thank you.
Thank you.
Thank you, Sanjeev.